because it is not decolorized or it is not affected by the acid. The cell wall has some glycolipids and special glycolipids in their cell wall, so that resist decolorization by acid and alcohol. Okay? Even after sitting in front, this guy is talking. You can get out of the class. What? So this is leprosy. Can you see the face? So leprosy is, sit down, is a very devastating disease. It a person having leprosy can have multiple skin nodules, patches, okay, and in severe conditions, the face can also look like this, leonine faces. So there are single lesions, multiple lesions, and you have some patches, and you can also have this down there nodules. So leprosy is also called as Hansen disease. So it is named after physician Gerhard Armer Hansen, and it is caused by Mycobacterium leprae. We all know it is caused by Mycobacterium leprae, which has a special cell wall properties just like tuberculosis. And it is primarily a granulomatous disease of the peripheral nerves and mucosa of the upper respiratory tract. Okay, and the primary external sign is skin lesions. Usually, a patient presents with skin lesions or some peripheral nerve thickening. So, it results in a lot of disabling deformities. And how it is transmitted. May be transmitted directly by direct contact when a untreated leprosy patient shed numerous bacilli from damaged skin. The skin gets damaged in leprosy, or even in severe conditions there is nasal discharge. So in the discharge you have lot of bacilli, mucous membranes of the mouth and hair follicles. When there is shedding of leprosy, the patient is untreated, the active bacilli is shedded. So that leads to transmission from person to person through aerosols or from lesions from the upper respiratory tract. So other mode of transmission is feto-maternal through placenta. Okay, and the last one is from milk of leprosy patient to infant. So most common is by direct contact. So in lepromatous leprosy, to a male is affected more commonly, but tuberculoid leprosy is commoner. Okay, so leprosy predominantly affects younger persons a young age group, that is less than 35 years of age, and the incubation period for tuberculoid leprosy is up to 5 years, whereas lepromatous leprosy is 20 years or longer. Okay. So what are the risk factors? If a person takes birth or resides in an endemic area of leprosy, or a blood relative has the disease, so that is a very close contact. And some North Americans, they have the increased risk of getting leprosy. So what is the possibility? There is simultaneous involvement of skin lesions and peripheral nerve thickening will be there, some abnormalities. Okay, so if the peripheral neuropathy of unknown type is seen in a patient in endemic area, that is called pure neuritic leprosy. Only we see peripheral neuropathy, person presents with peripheral neuropathy. Okay, in an endemic area, that is called pure neuritic leprosy. And when we can identify there is leprosy, if there is simultaneous involvement of cranial nerve 5 and 7, that is considered to be leprosy until proven otherwise. Okay, so what are the other differential diagnoses? Other granulomatous inflammations, granulomas, vasculitis or lymphoma are the differentials. We might confuse because this also present with nodules. Okay, so leprosy mainly grows in cool tissue of the body, cooler tissues, that is skin, mouth, respiratory tract, eyes, peripheral nerves, superficial lymph nodes, extremities and testes. So it is the disease of the cooler tissues of the body. Okay. Now, source of infection and route of transmission is not known, but the likely origins are said to be human respiratory secretions or soil. What happens is that in the body, inside the body, the leprosy is taken up by the macrophages and disseminates in the blood. But it replicates in the cooler tissues, as I already told you, skin, okay, mucosa, superficial lymph nodes. So it replicates in those cooler tissues of the skin extremities. So leprosy is taken up by the macrophages in the body, and it disseminates in the blood, but it replicates in the cooler tissues of the skin and extremities. Okay. It proliferates at 32 to 34 degrees centigrade, that is the temperature of the human skin. It, like Mycobacterium tuberculosis, leprosy does not secrete any toxins, and its virulence is based on the properties of cell wall. So even tuberculosis, you have read, the properties are based on the cell wall. Similarly, in leprosy, its virulence is based on the properties of cell wall. Okay, so like tuberculosis, immunization with BCG confers some protection against Mycobacterium leprae. Leprosy has two different patterns. They are different because the T helper, the cellular immune response to Mycobacterium leprae, determines whether the patient has tuberculoid leprosy or lepromatous leprosy. So in case of tuberculoid leprosy, what happens? The cellular immunity, the cellular response of the body is very high, very good. But the patients who have low immunity, low cellular response, so they usually contract with lepromatous leprosy. Okay, so tuberculoid leprosy, because a person can resist the infection, they have a good host immune response, it is a less severe form. In this, the patient presents with dry, scaly skin that lacks sensation, and they have asymmetric peripheral nerve involvement. It is asymmetric involvement. And lepromatous leprosy, what happens? There is poor immune response of the person towards the organism, right? So lepromatous leprosy is more severe form. The macrophage cannot contain the bacilli properly. So symmetric skin thickening and nodules are seen in lepromatous leprosy. Okay, it is also called as energic leprosy because of the unresponsiveness of the host immune system. So the host immune system cannot combat the bacteria. What happens in lepromatous leprosy? There is widespread invasion of the mycobacteria into the Schwann cells and into the endoneural and perineural macrophages, and that damages the peripheral nervous system. In advanced cases of lepromatous leprosy, Mycobacterium leprae can also be present in sputum and blood. Okay, and there are also some intermediate forms of leprosy other than the tuberculoid and the lepromatous leprosy. Those are called borderline leprosy. So as I already told you, what is tuberculoid leprosy? There is a high cellular immune response, and we can see very few bacilli in the tissue because the immune response of the host can combat the bacilli. So what happens? There is a T helper 1 response that leads to production of interleukin 2 and interferon gamma. Now interferon gamma, what it does, it mobilizes an host macrophage response, and it contains the bacteria, the bacilli, and the microbial burden is low in tuberculoid leprosy. And what happens in lepromatous leprosy? There is weak or absent T helper host immune response to the Mycobacterium leprae antigens. So if there is low immune response, low host immune response, what happens? There is no macrophage activation. There is no macrophage activation, and there is abundant bacilli in the tissues because the bacilli cannot be contained. Okay, so The net result is weak cell-mediated immunity and an inability to control the bacteria. So, leprosy is broadly classified, as I already told you, into lepromatous and tuberculoid type of leprosy. Okay, and these are the two polar forms of leprosy. Okay, because and other forms which falls in the middle are borderline and intermediate types. This is a widely accepted modified Radley-Jopley classification for leprosy. Okay, TT, that is tuberculoid, then comes borderline tuberculoid. This is high resistance. The host has high resistance. As we move down the line, we reach the lepromatous leprosy, that is LL. So that means the host has a low resistance towards the bacilli. Okay, so it is gradual, it is decreasing in order: tuberculoid, borderline tuberculoid, tuberculoid indefinite, mid borderline, that is borderline, lepromatous indefinite, borderline lepromatous, and lepromatous. So tuberculoid is highest resistance and lepromatous is lowest. So it comes down the line. So morphology, what we see in tuberculoid leprosy, it is usually presents as a localized skin lesions, and that are initially flat and red. But later what happens? There is that develops into irregular shape, and it enlarges. The skin lesion enlarges, and there is a peripheral induration and elevation of the margins, and that margins are hyperpigmented. And the central pale center, they have pale centers because there is central healing. So it begins as flat and red, it enlarges into irregular shape, and the margins are elevated, indurated, and hyperpigmented with pale centers because of the healing of the center. Okay, and in tuberculoid leprosy, what happens? Neuronal involvement dominates in tuberculoid leprosy. Nerves are enclosed with granulomatous inflammatory reactions. Okay, and if the nerves are very small, that is twigs, they are destroyed. So this is a picture of tuberculoid leprosy. If we can see that, can you see the pink line above the dark one? Okay, so that is the epidermis. This is a biopsy of skin. Okay, so that is the epidermis, and below the whole area, the light pink area, is the dermis. So epidermis and the dermis. Okay, so in the dermis you can see some patches. Can you see the patches? Those patches, right? So those are granulomatous, the pandermal, perineural vascular granuloma and lymphocytes. So there are nerves, nerve के around granuloma है, okay, vessel के around granuloma formation है. So those are localized granuloma formation around the appendages of skin, that is nerves, vessels. Okay, so this is a higher power view. In this you can see there is a granuloma formation. You have Langerhans giant cell. Okay, so this is around a nerve. So this is a case of tuberculoid leprosy. This is in the center you can see some spindle elongated cells, and also there is granuloma which is invading into that thing. So this is a nerve. It is a case of endoneuritis with granuloma eroding inside the nerve. So what happens? So nerves are involved, the granulomatous, because of the granulomatous inflammation around the nerves, nerve degeneration takes place, and what happens? What it causes? It causes skin anesthesias. So there is no sensation of the skin. There is numbness, and there is loss of any, if you touch, because of the touch sensation and the pain sensation, what happens? We are prevented from any trauma. But if there is a loss of touch sensation, there is no pain. Skin anesthesias, so there is numbness, there is loss of pain. even loss of touch sensation. If there is loss of touch sensation, what happens? The patient is liable to trauma because he doesn't understand where he is touching or what, even hot, any kind of sensation he can't feel. So that renders the patient liable to trauma in the affected parts with the development of skin ulcers. So skin and muscle atrophy is also there, okay, because of nerve degeneration. Patient eventually develops contractures, paralysis, auto amputation of fingers or toes, okay. Facial nerve, if involved, facial nerve involvement, because any nerve can be involved, so facial nerve involved can lead to paralysis of the eyelids, keratitis and corneal ulceration. What we see microscopically, as I already showed you, we see granulomatous inflammation as it is found in TB, and bacilli are almost never found. Why bacilli is not found? Because it is contained by the macrophages, right? And the granulomatous infiltrate erodes the basal layer of the epidermis, and there is no clear zone. As I already showed you, the thick dark line, that is the epidermis, and below was the dermis. So there is granulomatous inflammation in that transition zone between the epidermis and dermis. So there is no clear zone. That is also called as grain zone. That is found in lepromatous leprosy. Okay. The presence of these granulomas and absence of bacteria reflects strong T cell immunity. And now coming to lepromatous leprosy, what happens? In lepromatous leprosy usually involves skin, peripheral nerves, anterior chamber of the eye, upper airways, testes, hands and feet. Okay, but vital organs or CNS are rarely affected because, as I already told you, leprosy affects the cooler sides of the body. Okay, so the temperature, the core temperature of CNS or the vital organs are too high for the growth of Mycobacterium leprae. So this is the classical picture. You find lepra cells. What happens? They have large lepromatous lesions contain large aggregates of lipid-laden macrophages, and these foamy macrophages are called lepra cells or Virchow cells. Okay, and they are filled with masses of acid-fast bacilli. That is called globi. So like stick, parallel arrangement of sticks. Okay, I'll show you some pictures now. So you can see globi. So there are lots and lots of bacilli in lepromatous leprosy because of the poor host immune response. Okay, and the dermal infiltrate does not encroach the basal layer of the epidermis. So there is a clear subepidermal between the epidermis and the dermis. There is a clear area, uninvolved area by leprosy, that is called as grain zone. So leprosy, the tuberculoid leprosy is also called as paucibacillary. It also causes paucibacillary lesions are seen in tuberculoid leprosy, and in lepromatous leprosy multibacillary, because you can see lot of bacilli. So this is the picture of lepromatous leprosy. So in histopathology you can clearly differentiate between tuberculoid leprosy and lepromatous leprosy. Can you see the picture how different it was from tuberculoid bacilli leprosy? In that there were collection of granulomas around the nerves, around the vessels, but in lepromatous leprosy what happens? So these are all macrophages, and this is H&E stain section. Okay, and there is that dark epidermis, and below there is dermis, and that is filled with this tiny dot. Can you see? Those are all macrophages. Okay, in H&E you cannot see bacilli. Okay, so if there is a clinical suspicion, a dermatologist has told we are suspecting leprosy, but we are not sure. So we have to rule out the differential diagnosis. We take a punch biopsy from the lesion. Okay, and we get this picture. Now By looking at this picture, we get an idea that yes, this can be a case of leprosy. What do we do? Next, what we do? We apply which stain? As Zeal-Nielsen stain. So that is the picture. So you can see number of bacilli there. This is the Wade-Fight stain. That is also done for Zeal-Nielsen stain. What is the difference between Zeal-Nielsen stain of tuberculosis and leprosy? 5% and 20%. किस में 5% यूज होता है? ठीक है, उसको क्या कहते हैं उस Zeal-Nielsen stain को? Modified Zeal-Nielsen stain, right? And that is conventional Zeal-Nielsen stain. So that is this is a Wade-Fight stain. ठीक है, इसमें भी we can see bacilli. ठीक है, so these red compact masses we can see, that is globi. Can you see those red masses? See this. So all the macrophages are filled with those reddish color blobs, if you can make out. Okay. So in lepromatous leprosy, the ulnar and the peroneal nerves are involved commonly, and there is loss of sensation and trophic changes in the hand and feet will follow the nerve lesions. As I already discussed, there will be numbness, there is loss of sensation of touch, pain, any temperature sensation, anything. So in lepromatous leprosy, macular, papular or nodular, any kind of lesions can be seen in face, ears, wrist, elbows and knees. And with progression, the nodular lesions will coalesce. Suppose in face, the nodular lesions will coalesce and yield a leonine faces. Okay, they are anesthetic and hypoesthetic skin lesions. In lymph nodes also we can see aggregates of bacterial filled foamy macrophages in the paracortical areas and the germinal centers. And as the disease advances, these aggregates of macrophages are seen in the splenic red pulp and liver. In advanced cases, the testes can be extensively involved, leads to destruction of seminiferous tubules and consequent sterility. Next class, if I have time, I'll take a test.